CUHK Community eHealth Care Project Symposium on the role of digital health in integrated care of older people. While you're waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the CUHK Community eHealth Care Project. Please enjoy. The slideshows showcase the achievements and experience of the JC eHealth project from the aspects of different NGOs at their elderly centers. We will be starting the symposium at 2:30. Welcome to the ICOPE Community eHealthcare Project Symposium on the role of digital health in integrated care of older people. While you're waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the ICOPE Community eHealthcare Project. Please enjoy. The slideshows showcase the achievements and experience of the JC eHealth project from the aspects of different NGOs at their elderly centers. We will be starting the symposium at 2:30. Good afternoon, ladies and gentlemen. A very warm welcome to the CUHK Community eHealth Care Project Symposium on the role of digital health in integrated care of older people. While you're waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the CUHK Community eHealth Care Project. Please enjoy. The slideshows showcase the achievements and experience of the JC eHealth project from the aspects of different NGOs at their elderly center. We will be starting the symposium in 5 minutes. Distinguished guests, ladies and gentlemen, I welcome you back to this online symposium on the role of digital health in integrated care of older people of CUHK Community eHealth Care Project. I'm Piu Chan, the Master of Ceremony for the symposium. We now start the afternoon sections. May we invite Associate Professor Rashma Aid Merchant, Head of Divisions of Geriatric Medicine, Department of Medicine, National University Hospital, Singapore, to deliver her talk on rapid geriatric assessment using mobile apps in primary care. Professor Merchant, please.
Assessment for the future. Thank you very much. I'm available for any questions if you have. Thank you. Thanks. First, I would like to thank the organizers for inviting me to speak on rapid geriatric assessment using mobile app in primary care. As you know, the world population is aging, and the definition of healthy aging defined by the WHO in 2015 was basically a process of developing and maintaining the functional ability that enables well-being in older age. So healthcare in the 21st century, we need to move from disease to function, population-focused, adding life to years, and develop age-friendly health systems. So we really need to move towards redesigning care. So there was a paper a few years ago that says we need to redesign care for older people to preserve their physical and mental capacity. So WHO guidelines and community-level interventions in integrated care. Essentially, what is suggested is assessment of individual impairment or declines in capacity, interventions to improve nutrition and encourage physical activities. And if you find somebody with decline in capacity, we do need to refer to physician for a comprehensive geriatric assessment for diagnostic confirmation, treatment, and management plan. So you may be familiar with the report on Decade of Healthy Aging that was released last year, and although it has various components, but I've only mentioned two of the components here. Number one is ensure that communities foster the abilities of older people, and number two, deliver person-centered integrated care and primary health services responsive to older people. So countries worldwide are moving towards implementing the ICOPE model of care, and a town in UK called the Felixstowe is one of the first places in the UK to implement it. So frailty and prevalence. So in Singapore, the prevalence of frailty is about 6%, pre-frailty 37%, and robust 57%. And interestingly, you see prevalence of frailty increases with age, and if you're above 80-year-old, 15.4% may have underlying frailty. There is a dip between 75 and 79 years old, where the prevalence of frailty is about 6.3%. Similarly, there are differences in ethnic groups, and the three main ethnic groups in Singapore are Chinese, Indian, and Malay, and the prevalence of frailty was highest in the Indian, followed by Malay and Chinese. Frailty, as we know, is associated with poor quality of life. So why primary care? Primary care is the best site for opportunistic screening. If you look at the triangle, most of the red peak are actually in the hospital setting, and it's basically complex case management with 50% of healthcare cost. Primary care essentially manages the bottom two layers and maybe half of the orange layer, which is multiple chronic. So population health management in primary care level will be able to target at least 2/3 of the population. And the earlier you intervene, the lower the cost for healthcare in long term as well. Primary healthcare in the 21st century, you realize until very recently we were focusing more on the medical model, which is the treatment, the illness, the cure. But essentially, most primary healthcare are now moving towards health promotion, are moving from illness to health, are moving from cure to prevention, care and cure, basically comprehensive care and joint responsibility. We all know that there are constraints in primary care such as time, expertise, skills, and a very limited number of geriatricians. So there was an editorial not long ago on involving primary care healthcare professionals in geriatric assessments, and there are many tools available out there, and the ones you may be most familiar with may be the Keyhone's checklist in Japan, and rapid geriatric assessment, which has been carried out in many countries across the world. The other geriatric assessment tools includes Vulnerable Elder Survey, Gerontable Frailty Screening Tool, Easy Care, and there are various other tools that are available in different countries. Geriatrician, to some extent, I would say is a rare breed and declining geriatric workforce. This was a paper published by Professor John Morley in 2017 to basically show number of geriatricians per 10,000 population above 65-year-old. And UK has got the best numbers of geriatricians, but in the US, in terms of geriatricians per older adult, 2030, it will be one for every 4,254 older adults. So rapid geriatric assessment, essentially, it has got 4 tools in it. There's a frail scale to screen for frailty, CUHK for sarcopenia, which is available in many international guidelines for diagnosis of sarcopenia, a SNAC for anorexia of aging, and rapid cognitive screen. It comes with the assisted management pathway, which I'll describe further later. Essentially, fatigue, you need to rule out for reversible causes like low B12, hypothyroid, obstructive sleep apnea, depression, orthostatic hypotension. If you have problem climbing one flight of stairs or walking one bus stop, you may want to refer for physiotherapy or exercises. If you have more than 5 illness, we worry about polypharmacy. And for loss of weight, there's a mnemonic called Meals and Wheels to rule out reversible causes. So rapid geriatric assessment in primary care, we've got various publications on it if you want to refer to it. We also developed a self-assessment tool. Essentially, is an app that measures all components, including the well-being of caregivers as well. It's available in Chinese and English. This is what it looks like, a rapid geriatric assessment app. It's got the rapid cognitive screen, caregiver well-being scale, and you can actually choose what you want. And if you score positive for fatigue, it will go to depression. So you need to assess it for depression. And if you've got anorexia of aging, it will go to the Meals on Wheels mnemonic, and it's all automated. This is what the result screen looks like. So again, if you do screen positive for frailty, it will tell you your first score is 4 out of 5. And then, if you click on it, it will give you an advice sheet about what you need to advise your patients. So this is just a picture of screening in primary care. And again, these are not nurses, they're just coordinators. And they can give immediate advice on the spot. So this is essentially when we train the primary care physician and we brief them. This is what we actually showed in terms of assessment. And for individual components of the frail, there was targeted pathways. So we told the primary care doctors, the patients have fatigue, yes, we will rule out for depression, we will rule out for sleep apnea. But when they really see you, you need to rule out hypothyroidism, anemia, and orthostatic hypotension. For those who had mobility issues or problem with climbing stairs, we did recommend them for physical exercise and a vitamin D check, including nutrition advice if there's no contraindication for high protein diet. For those with more than 5 illness, we suggested referral to the pharmacist for recon. And for those loss of weight, again, their primary care doctors were informed about it to investigate for loss of weight. So essentially in primary care, we found the prevalence of frailty was 7% and pre-frail 30%. And in terms of breakdown, there was 6.4% had weight loss, 10.1% had 5 or more chronic illness, 15% had problem walking one bus stop, and 12.5% climbing one flight of stairs. For fatigue, it was 15.7%, but interestingly, for those with fatigue, 82.9% reported depression. And of those, 10% had moderate or severe depression. The prevalence of sleep apnea was relatively low, but again, these were patient as they reported themselves, not from the caregivers. CUHK, as I said, for sarcopenia, we found 18% of the primary care population was sarcopenic. And on that, when we looked at the individual component, almost 10% had problem lifting 4.5 kilos. Almost, 20%, slightly less than 20% had difficulty walking across the room. Similarly, about 1 in 4 had issues with transferring from chair. Difficulty climbing up a flight of stairs, almost 1/3. And slightly less than 15% had fallen in the past year. So again, if they're sarcopenic, they'll be given an advice sheet about what they need to do. It can be air printed as well. Anorexia of aging, we found 15% had underlying anorexia of aging based on the SNEC scale. And if you did score positive for it, you need to answer further questions on the Meals on Wheels and enlarging it. This in the next slide. You can see that 10.2% reported difficulty swallowing or choking. 5.7% had problem with chewing, and 6.8%, basically, they consume alcohol and other things, probably with early satiety. You may be familiar with the integrated care for older people, and I believe you do have a few talks on this in your conference. Again, there is an app available, and it's targeted as well. And again, you can see they have assessment for cognitive decline, for limited mobility. The advantage of this is they do sit to stand 5 times. Nutrition screening, the additional 2 aspects is visual impairment and hearing loss, depression and depressive symptoms. So you could use the ICOPE tool to complement some parts of the aspects, including visual, hearing, and sit to stand test as well. As mentioned earlier, we did publish a paper on the practicability and reliability of self versus administered rapid geriatric assessment. So the self-assessment did really well on all the components like weight loss, falls, except for those questions with ambiguity, like walking 1 bus stop or climbing 1 flight of stairs. And they got a little bit confused with some and a lot. And going forward, I think it would be good to have like a scale from 0 to 10 and get them to rate how much difficulty they have climbing upstairs or walking 1 bus stop. So to complement the rapid geriatric assessment that was done in primary care, the bar chart on the left just shows that if you're above 80-year-old, you have much higher prevalence of frailty, pre-frailty, and sarcopenia. So those who pre-frail, we did offer them cognitive stimulation therapy and exercises in the nearby community centers. During peak of COVID-19, we had to basically do it virtually. So this is just, just a photo when the restrictions were lifted. The future is virtual geriatric care. So virtual geriatric care can be assessment or intervention. Assessment, essentially, you can do anything. Geriatric assessment, physical function assessment, cognition, wound care. You can also manage end-of-life symptoms virtually. Interventions, again, there are a lot of publications out there about falls prevention, managing polypharmacy, caregiver training, reduce social isolation, CST, and obviously the orange box just tells you, the huge amount of work that can be done virtually, including teledentistry, teleophthalmology, and so on. During the peak of pandemic, we conducted a small study on the acceptability of digital technology and tele-exercise. It was difficult because the consenting has to be done digitally during circuit breaker period, and a lot of participants were not keen to participate just because of the consenting. However, for those who did participate, 71% owned their own device, 79% agreed the technology will keep them independent longer, 86% had access, but despite all this, 57% were still apprehensive about using technology. So after participating in Digital Happy, which is a dual task exercise, which is conducted in the community, 45% feeling stronger than before, 48% improve in spirits, 40% improve in mood, and 38% improve in memory. So the future is basically we need to do it together. We need to keep healthcare affordable, accessible, and of good value for Singaporeans and elderly across the world. And the current system is we label them as frail elderly. They end up in the hospital with confusion, with delirium, with falls and fractures. It's hospital-based, it's episodic, it's fragmented and disjointed. So the future, essentially, we do want to screen all the adults at risk upstream. We want to provide timely identification for preventive, proactive care and shared decision-making. We want coordinated, person-centered care. And we went by community for community and mainly the primary care. So in conclusion, with limited number of geriatrician, a rapid assessment with immediate management plans by non-geriatrician or older person themselves is the future. RGA app incorporates frailty, sarcopenia, nutrition, and cognition screening. It can be done in less than 5 minutes or maybe at most 10 minutes. COVID-19 pandemic has accelerated technology adoption, and healthcare system should explore self-rapid geriatric assessment for the future. Thank you very much. I'm available for any questions if you have. Thank you. Thanks.
Thank you for your sharing, Professor Merchant. So here's come to the 5 minutes Q&A sections. Ladies and gentlemen, you're welcome to raise your questions. Please type your question in the chat box, and Professor Merchant will try to answer it accordingly. Hi, Professor Merchant?
Hello, yes, I'm here.
Yeah, so the first question is how to encourage the elders to use the assessment app?
It's not as easy as we think, but one of the best mechanisms in place is have peers do assessment for peers themselves. So we do have the volunteers in the National Library who are very tech savvy. So we are hoping in the future that the volunteers who knows how to use technology will help those who are not very familiar with it and help do assessments.
Understood. Yeah, just we also need to just do it step by step, right? Okay. So just once again, thank you for your here. And thank you very much for your just sharing. I think it's very insightful for us. So I think there's no more questions at this moment. So once again, thank you for your presence. Thank you very much.
Thank you. Thanks.
Next, we would like to invite Professor Piu Chan, Professor and Director, Department of Neurobiology, Geriatric and Neurology, Puhu Hospital of Capital Medical University, China, to give a talk entitled Integrated Care for Older People Screening Tool for Measuring Intrinsic Capacity. Professor Chan, please.
For the introduction, and also I'd like to thank the organizer and particularly Professor Jin Wu for the invitation. So I'm going to talk about some of the experiences we had in mainland China in terms of how to use digital medicine to manage people. And so as the Professor Merchant has already talked about, we're facing really a challenging for population aging, particularly in China, because the growth rate is very rapidly for the elder people. So in this WHO Health Aging 2020 to 2030, there are a couple of new concepts have been brought up, particularly intrinsic capacity. I'm not going to describe that. And another concept is the functional ability. Really, that's a little bit different from what we used to think about, is to basically care more about disability. But in this new functional ability concept, is really we need to encourage people to do what they like to do. So it's not limited by their ability, because that helps can be provided from both medical field and also the society, government, and also technology. So I think the goal is to really reach a quote unquote healthy aging status. That's basically like what the previous speaker has mentioned, is how to make a person-centered management or life cycle management. So I think that management becomes very critical. So in order to do that, in the WHO initiative, the intrinsic capacity that consists of 5 components to measure the general functionality of the individual. But the goal is not end there. The main goal is to find what are behind the intrinsic decline, capacity decline, and how to intervene or manage those causes, and then that can lead to better functionality of the individual. So to do so, I think the intrinsic capacity as a intro kind of screening tool to help us to identify the most vulnerable risk people. So for that, in China, we have adopted it and translated into Chinese version. And pretty much for the IC measurements, we can translate that into a more objective measures. So use those measurements. We have been carrying out a number of studies in both hospital-based and community-based studies. Particularly the results I'm showing here demonstrated that the intrinsic capacity is declining with aging, particularly for the cognition and the motor function. And those decline is very well correlated with aging and also disability, including frailty. So that really indicates intrinsic capacity is a good predictor for the outcome of elderly, and has a better prediction or correlation with frailty and quality of life. In this analysis, we, after controlling for comorbidity, which is also a very important factor in determining the disability and the quality of life of the elderly, we found that actually intrinsic capacity plays a more important role as comparing to comorbidity. So certainly, the screening of intrinsic capacity becomes a very important measures or the rules or pathways leading to better management of patient. And but there are limitations, as what the Professor Merchant has mentioned. The IC tours, there are many of them, and however, most of them are even developed in a version like apps or iPad or PC driven, have been used, but it has been given by a care provider or doctor or nurses at a given time and places, and you cannot really to measure in a more real life kind of situation and used as a continuously monitoring because intervention is the goal of really using the IC tools and then leading to a better functionality. And also the current, even we use app or the electronic device to measure IC, it's mostly a transient event and not detectable when something happens. So it cannot give a full picture of the elderly, life, basically in a more home or nature environment. And also it cannot help us to basically understand the cause and then introduce intervention or care in a more quickly or proactive fashion. And also, I think constant education or coaching is needed if we want to make the individual, the elderly, have a better functionality or quality of life. Particularly in China, where even we have a good, we have pretty spread over primary care, but really the referring system or continued management is lacking. So that in some way, the management of elderly is kind of, not in a smoothly way. So in order to solve this problem, thinking of how to build a patients or elderly-centered continuous management system. I work with a few other international experts, particularly in the neurological field, and they come up this idea that we need to build a continuous management by incorporating or integrating, health professionals at different level, at different place, and then also how to integrate institutions that can provide different services. In order to achieve that, I think a continuous management tool is needed. Of course, traditionally in a society that the primary care and specialty training, specialty care is better managed. This may not become a very critical rules. However, it's not a continuous measurement to really reflect what happens in real life at home or in a more natural environment. So in China, the government has really promoting telemedicine in different ways, particularly from the traditional telemedicine kind of institution to institution kind of way. The government now encourage hospital to open up the physical wall basically to carry out telemedicine from institution, like from hospital to patients or to elder people. But in addition to that, another formality of the virtual hospital, I call it, or telecare, is also established in China, where a company or entity can work with a hospital to build an internet-based caring system. And then all professionals, including doctors and nurses, can join this virtual hospital no matter where they are. So that really help us to build a continuous management or kind of nature referring system, or to build a integrated team of care, no matter where they are, which provinces they're registered, or what profession they are, or what kind of specific disease caring or rehab or kind of other educational professionals can work together. So that really give us a significant means or tool to realize continuous management of patients or elder people. Quite simple, as I mentioned here, I'm not going to describe in detail. So basically, this is a virtual hospital. You have to have information system that managed by the company, and then a hospital that will be sponsoring this virtual hospital. Through that, doctors or nurses can be registered, but it's not going to be limited by which hospital they belong to offline, and also which provinces they are. So in that way, we can build kind of multidisciplinary teams virtually. And so through that, we have been used this to caring Parkinson patients and Alzheimer's patients, because where the patients is more active, they like to have experts' opinion in their treatment or diagnosis, which cannot be better provided locally because they lack the expertise. So in this system, it's like an app, but it's virtual hospital, can be used for messaging consultation between the doctor and the patients, and also can do video, practice facing to face between the patient's doctor or with other, the companies or other professionals, but together, particularly with, primary physician or local neurologist, geriatrician, to work together without a barrier, physical barrier, to comment or consult on a specific individual. And also through this means, we can provide rehab, care to patients at home, either through just watching the video or through in person by a video conferencing way to instruct how the subjects or the caretaker can basically help the patients. So in addition to that, we have built a app that can serve the purpose linking the individual, the patients with the health providers, but not in a more consultation way. So they are free of charge, information can be distributed by letter, bi-directional. The patients can provide their daily prescription or information on their health or certain scales they can basically finish by themselves, and the doctors or caretakers can send them in specific, based on specific needs, because freezing of gait or cognition for coaching or for education. Through this, we have been able to, in this specific virtual hospital we established, we have doctors coming from different provinces across China. Now we have around 500 doctors and then professionals, nurses registered, and also we have patients come almost 10,000 patients being managed through this virtual hospital for the last 2 years or so. And of course, most of the patients are brought up by doctors who see them at the clinical hospital, and then they like to, build a relationship, or through their local neurologist, geriatrician, or primary physicians, so they can establish that kind of relationship, mediated by the patients, and then basically drag their local doctors come up to establish relationship with expertise in the big cities or special centers. So from here, we can see really give a very high adherence, and also a lot of the questions or issues resolved through the virtual hospital are quite interesting, because most of them are related to, the general symptoms like depression or sleep or psychosis, also hypertension, frozen of gait, but also some related to a diagnosis or basically Parkinson's disease, particular like motor fluctuation management. So really give a very good benefits to both doctors and patients to really build a more continuous management relationship. But in addition, we try to develop a better tools or wearables that can really overcome the difficulties for elder people to use those digital tools like apps or other measurements. So like we developed a shoes that incorporate equipment that can help us to measure the real activity of walking of the patient's motion. But in the meantime, by integrate a sensory stimulation system, we can help really the patients to improve their frozen of gait. Of course, along the line, we hope to build more the wearable device that can measure more closely to the intrinsic capacity measurements, so that we can really manage the patient from high-risk individual for their prevention or progression or diagnosis, and also other rehab, so that really, not just a, linking in terms of communication, but really provide a feedback that patients can really get instant or better, improvement in their health. I think that's really the final goal, the ultimate goal of digital medicine. But there are other challenges like security, reimbursement issue, because it's now covered by the National Reimbursement Plan. And also, I think there are, a transition from more face-to-face care to, digital care, if I call it. But I think this probably is the trend or the future of for the person-centered management, in which we need to have technology that can continuously, remotely monitoring the vital signs or basically health information of the individual that through the digital tools can basically give advice or give directly the information of the person's health status. In addition, automatically, artificial intelligence may help basically a better management of the patients. So now we're starting working with companies really try to, in parallel with what we have already established, the care team with the person, but integrating the system with more artificial intelligence mediated through kind of wearable or digital medicine, so that we can really build a called digital twins in the future. Basically, we can in parallel of what we are doing right now, person, caretaker to persons, but in the future, I think machine learning, artificial intelligence can in some way help to really expand the efficiency and then really help a lot of this more precision medicine and personality medicine integrated into the patient's care. So I will stop here. Thank you again for the invitation, and thanks for your attention.
Thank you very much for your presentation, Professor Chan. Here comes to the 5 minutes Q&A questions. Ladies and gentlemen, you're welcome to raise your questions. Please type your questions in the chat box, and Professor Chan will try to answer it accordingly. Hello, Professor Chan. So the first question is, do you have any suggestions if we use the screening tool in Hong Kong?
I think that probably Hong Kong is in a better position to do this. Why we start from the technology, digital medicine, first is to really overcome some of the deficit of the medical system in the mainland China, where the institution, among the institutions, they are lacking really efficient referring system, and the patients can go anywhere they like. But I think in Hong Kong, the primary physician or primary medicine really doing very well. That's proven by the life expectancy, the data from Hong Kong. So, however, I think how to giving a better or more, as I said, precision and individual kind of medicine that really what brings in is more expertise, more focused attention on some deficit. I think that's really what the intrinsic capacity, function, ability intend to do. We cannot solve everything, but we want to help the L people to realize their dreams, what they want to do. They want to walk, they want to think better, they want to travel to the world, they want to solve some of the disease or comorbidity issue that can help them function better. So I think technology is not an issue, and I think Hong Kong has better infrastructure to implement, but I think the issue is then how to integrate between the private sector and the public sector.
Thank you for your answers. So the second question is, did you encounter any difficulties in engaging other community stakeholders to implement ICOPE?
Not really. I think right now the issue in mainland China is the ICOPE is very well accepted. But however, I think it's still kind of more in a research kind of situation. Basically, the people in the big hospital, they try to study or try to understand better of the ICOPE or intrinsic capacity. So the primary care workers or the people in the society are not really integrated. They are more kind of being a part of the research work. We need really to do this in a more practical way with the goal of solving the problem, help the primary physicians. So I think this should be a more bottom-up kind of strategy. However, that's just the opposite in mainland China right now. That's why I say Hong Kong, Singapore, or countries that primary care has a really play an important role for people's general health. And I think that certainly can do better in terms of using ICOPE or IC.
Thank you, Professor Chan. So the last question is, have you noticed socioeconomic disparities in using telemedicine in your studies?
That's the key question, the key problem right now. Because in order to really make the virtual hospital a service provider rather than a portal for consultation, so we implement a fee service rather than everyone just want to asking questions. So now also because this is a virtual hospital managed by the government, because every information has to be stored in the government hopper that's monitored like a hospital. So we have to follow the medical practice way. So that's why we only bring people that we have seen, or people that have seen by their local doctor who had a kind of relationship with the experts. And so certainly for additional fee, which is not covered at this moment by national insurance, is a very important limiting factor. But I think a lot of patients gradually accepting this, because otherwise they have to travel to Beijing, Shanghai. That's even more costly. But I think this shouldn't be stopped here. I think it should be become a common tool for most people. So I think the barrier for reimbursement for commercial insurance will become a tool, because fundamentally what we do use this virtual hospital digital medicine is for all the people. So it's really the partner, I would call it the partner of insurance, no matter it's government or commercial insurance, because we're managing them. It's not the insurance itself. So I think this will happen. I think that when this happens, and this system will be much better welcomed by everyone.
Okay, once again, thank you for Professor Chan, your participation, and also your insightful sharing. Thank you very much.
Thank you.
Thank you. The next section is presented by Professor Bruno Vellas, Professor of Medicine, Head of the Suhongtupu, Toulouse University Hospital, France. As Professor Vellas is occupied by other business, he therefore provided a pre-recorded video for us to share his topic on the first ICOPE remote monitoring platform in the Occitania region, France, with all of you.
And I will speak now about our experience with the WHO ICOPE program in clinical practice. As you know, our healthcare system is not adapted to the aging of the population, and the result is a growing number of dependent old people. Now we have some recommendations from the WHO to change our practice to go more from prevention and more to maintain function. And this must be done at the primary care level. For the WHO, healthy aging is not to don't have a disease, but is to maintain our function to continue to be what we do and to do what we like. And to do that, the WHO have identified 6 functions that we need to maintain, that are nutrition, cognition, vision, hearing, locomotion, and nutrition. The target population for ICOPE is robust to prevent frailty and to prevent dependency. The ICOPE program have 5 steps. The first is a screening. Second, when we have some positivity at the screening, is to do a deeper assessment, like a geriatric assessment, to propose a preventive plan, to monitor the subject, and to engage the community to have all the resources needed. For the screening, we have some simple questions that were defined by the WHO because they were likely predictive to some events. For cognition, is mostly orientation and the 3-word record. For mobility, is a share-rise test. For nutrition, is looking at poor appetite and looking at weight loss. For vision, we look at risk factors like diabetes, blood pressure. Hearing, we do the Sestel test. And for the depression, we ask if the people in the past 2 weeks feel to be depressed or if they lose the interest to do what they like to do. We have done some validation about some of these items, and for example, you can see here that to have some problem on the orientation is highly predictive to have cognitive decline, but if they don't, the people will don't have cognitive decline in the next 5 years. The same for the share standing step. We have been able to change a little bit the cutoff. They need to do that in less than 14 seconds before 80, and it is 16 seconds after 80 for the share rest. We have been able to digitalize all the program with some apps that people can download in Europe. So will be possible to download soon in other countries. All the data go to a secure website for medical data. And we have some telehealth nurse that can survey the patients that are at home. You can see here, the people can use the apps or they can go to vocal robot. They can do that by themselves or that can be done by the primary care physician or nurse or healthcare professional. If everything is normal, we follow that every 6 months. If it is abnormal, we do a deeper assessment. And we have just started this program after the blockout, after the COVID 1.5 years ago. And now we follow more than 19,000 subjects digitally. The mean age is 74 years, with 61% women. We have done more than 30,000 step 1, baseline and also follow-up. Some subjects have more than 2 years of follow-up. Self-assessment is a little bit more than 2,000 step 1. We have done step 2 in almost 2,000 subjects, and near 5,000 healthcare professionals have downloaded the application. You can see here some of the data. The mean age is around 74 years old, 60% women, 40% men. You can see we see some vision worsening in 20% of the population, objective cognitive decline in 32, mostly MCI or early MCI. We can see some hearing worsening in 28% of the population, feel to be depressed in mostly 30% of the population. We have some mobility problem, unable to do the share rest in 11% of the population and weight loss in 11. What is important with ICOPE, we are able to see this subject before that they worsening and they go to the emergency. For that, we are able to catch at home and to help them to maintain function on one early stage. Here is some result of the step 2 that we have done in almost 2,000 people. They were a little bit older, 78.8 years, the same proportion of men and women. And you can see here the mean MMSE is 24.5. We can detect people that have MCI, maybe some have early AD, but most are normal cognitive function. The GDS is more than 1, is more than 500 subjects. The SPPB is around 8.8, and with 30% have some past history of falls. And you can see here that 20% have some risk of malnutrition and 5% are already malnourished. I remember to you that it is older people living in the community that we are able to follow with this system. And we are able to catch them, and in those that have a step 2, you can see that we have 22% that are robust, 41% already pre-frail, and 22% frail. So that is a possibility to be able to identify the frail people among the community. We have done a survey in 1,100 senior citizens, and you can see that more than 80% are satisfied or very satisfied about the program, and only 1% are not satisfied. All these tools are now accessible in France. The Social Security in France now start to pay the healthcare professional to do ICOPE step 1 and step 2, that it become part of the clinical practice, that we don't have to wait too much to see the patient part of the geriatrics. We have some web seminar where we can learn to the healthcare professional how they can do the step 1 and the step 2. We are building now in Toulouse, close to the Geroscience building, this center for prevention of ICOPE. And as you can see here, with aging, we have a decrease of intrinsic capacity that brings a decrease of function, and we need to be able to maintain this function as much as possible to be able to prevent dependency. That is the aim of the ICOPE program. To finish, ICOPE approach enables to identify older people with decline in physical and mental capacity and provides the evidence-based intervention that contribute to prevention of loss of autonomy. It is critical to make implementing care for healthy aging as a priority political agenda by scaling up the ICOPE approach, provide the ICOPE intervention under universal health coverage so that every older person can have an access to ICOPE screening, assessment, and intervention without financial burden. And of course, we need to have the capacity building for health and care workers in primary care, and the use of digital technology are key enabled to implement ICOPE that will be now developed nationwide in France, and we are working at the European level with the WHO. Thank you.
Although Professor Vellas cannot join our live symposium, I believe you could be inspired by his presentation today. Ladies and gentlemen, now we will have a short break, and please come back at 3:30 for the panel discussions. See you soon. While you're waiting for the next sections, you may browse our online platform. The link of the platform is in the checkbox now. You can find out the content of today's symposium, such as today's rundown and speaker's biography, as well as the background, findings, and achievements of the Jockey Cup Community eHealth Care project. Ladies and gentlemen, welcome back to the symposium. We now start the panel discussions on future development of digital health in integrated care of older people in Hong Kong. May I first invite our moderator, Professor Samuel Y.S. Wong, Professor and Director, the Jockey Cup School of Public Health and Primary Care, the Chinese University of Hong Kong. We would also like to invite our discussant, Dr. Elsie Hui, Service Director, Primary and Community Health Care, New Territories East Cluster, Hospital Authority, Professor Angela Leung, Deputy Director, WHO Cooperating Center for Community Health Service, School of Nursing, the Hong Kong Polytechnic University, Ms. Tammy Leung, Service Director, Aberdeen Kwai Fong Welfare Association Social Service, and Dr. Joyce Tang, Medical Director, United Christian Navajo Community Health Service. I'll pass the mic to Professor Wong, please.
Thank you for the kind introduction and welcome to these sessions on the future development of digital health in integrated care of older people in Hong Kong. We have a number of important stakeholders, especially in the community, and to talk about this digital health in integrated care development. So maybe we can take turns, and I believe many of the speakers have prepared the PowerPoints. So maybe we can start with Dr. Elsie Hui, Service Director, Primary and Community Healthcare of the NT Cluster Hospital Authority. Please, Dr. Elsie Hui.
Thank you. Can everyone hear me?
Yes.
Yeah, thank you. And can you see my slides?
Yes.
All right. Thank you for the kind invitation. We appreciate the opportunity to share some of the applications in digital and telehealth in chronic disease and also elderly care. First example, I actually have to thank Professor Wong because his team is involved. It's a simple pilot study looking at how a telemonitoring system can replace clinic visits among patients with high blood pressure. The aim is really to see if it's a safe and feasible way to replace doctor assessment so that we can empower the patient, save them time from traveling and free up some precious healthcare resources. So the partners included Family Medicine Department in my cluster in New Territories East, the Chinese University of Medicine, and also I believe it's an app developed by the NGO. So the workflow is simple. Patients encouraged to take the blood pressure at home, and the app is able to record the blood pressure just by scanning the reading on the blood pressure machine. And the data is captured and stored. Not only the patient can see a continuous reading and trend, but right before the follow-up at around 11 weeks, the doctor can look at what you call like a report card of the patient. At the same time, the patient's asked to complete an online health survey form, mainly asking them about their compliance and any symptoms. And if the patient passed with flying colors, then there's no need for them to come back to the clinic. The nurse will inform them, and if the patient is agreeable, then they just need to refill the drugs. Alternatively, if the blood pressure control is not so good, or if the patient still insists to see the doctor, they can come to the clinic. Up to recently, we had about 50 participants, and the retention rate was very high. And they achieved good blood pressure control. And indeed, we were able to save some visits to the clinic. So actually, this model is safe and is very patient-centered. The patient gets involved in their own management of the blood pressure. And the doctor can then spend more time on patients who have poor control or are more complicated, while being reassured that the patient using this tele-BP follow-up is also quite safe. So if this could be scaled up, you're talking about hundreds of thousands of patients under follow-up for the high blood pressure or diabetes in our primary care clinics. The other example I want to quickly go through is the use of telecare in the community setting. I apologize for the abbreviations. Essentially, the COST involves community nurses and also the ICDS program, which supports patients who leave hospital and also residents of elderly homes. And we've explored a lot of applications. For example, in wound management, the nurses can take photos and share with the supervisor and also monitor the wound care in the elderly homes. So during the fifth wave, actually of just a few months ago, this whole thing exploded, and it was really useful for us to support our patients in the community in whatever way, whichever form, by phone, by Zoom, by WhatsApp. This just shows the doctor giving consultation. If you remember, there was a lot of elderly home residents got COVID, and the doctor would assess them and prescribe the antiviral drugs on the same day. So we're able to treat the patients in a timely manner. These patients have just been discharged from the hospital, and again, the doctor and nurse and allied health staff are able to monitor their progress and also prescribe some home rehabilitation. And likewise, the community nurses were able to provide wound care and just supervise with the, say, maybe a family member or carers facilitation. They are able to provide wound care or urinary catheter care to patients. You must bear in mind at that time, you know, things were chaotic in Hong Kong, and this was a really innovative way to keep the staff and the patients connected and providing timely and professional treatment to our citizens. So this is all I wanted to share. This, again, when we set up these outlying posts in the quarantine centers, our staff rapidly adopted telecare, even in the most unfamiliar settings. So yeah, they were in this slide just illustrates that they were checking out patients with acute gouty attack. So I think this is my last slide.
Thank you very much, Dr. Elsie Hui. I think we can leave the discussion after everyone speaks. Thank you. So the next, may I invite Professor Angela Leung, who actually earlier spoke about the ICOPE training in Hong Kong, and now we would also like to invite her to share her opinions and thoughts about future development of digital health in integrated care of older people in Hong Kong. And just to recap, she's the Deputy Director, WHO Collaborating Center for Community Health Services, School of Nursing at the Hong Kong Poly University. Please, Professor Angela.
Thank you, Professor Wong, for introducing me, and it's my great honor to join this panel. For this panel, I think we focus on the future development of the digital health. So with this title, I think of a few things that I'd like to share with you. Let me share the screen. Is that okay to see my screen?
Yep.
I think that the issues here is that the WHO actually has already developed the app, which I've mentioned it just now in the previous talk. But the app is very comprehensive in a way that it provides 8 languages, including Putonghua, English, French, and some other languages. So because of the international perspective, so somehow this app cannot be changed easily. But the good thing is that it is really following the guidelines and the handbook provided by WHO. But the downside of here is that it is connected to another app. So this app basically is good in a way that it is for assessments, including the screening and comprehensive assessment. But when we are doing the screening too, one of the items is to check out the hearing capacity, and that hearing capacity is connected to another app called Hear WHO. So that Hear WHO, I downloaded it, I tried it, but I think the downside is that it is using Putonghua to speak to the audience. So I suspect that this may not be easily understood by everyone in Hong Kong. So that's why we do not use these two apps while we are doing the ICOPE projects in Hong Kong. But I can see the good things about this WHO ICOPE app is that it is really comprehensive, it is user-friendly, and it can be used by the clients themselves if they follow the instructions over here. But one thing is that it has to be somebody who are literate, who can read the languages, the instructions in the app. So if we are asked to improve the app here, I would say that it would be nice if it can have some voice-led function so that the voice can actually lead the clients to do the assessment by themselves. But I think if we use it for mainland China, I think that is a good one because first of all, the language is suitable for them. It's using Putonghua, as I say, and the characters are simplified Chinese, and that would be easily understood. So I can see that the WHO ICOPE app has some limitations for us to actually use it in Hong Kong. When we look at the overview of the development of the digital health, I would say, obviously, there are some pros and cons. The good things about the digital health is, of course, that the digital data can be kept for a long time, and it is easily used by people, and we can observe the changes, the so-called the trajectory of the clients, and see how different the performance is when we compare the baseline data. So it is not difficult to work out some graphics to show the changes of the health status. And the other good point for using the digital data in digital health is that, of course, we can easily do some subgroup analysis and find out who are at risk. Just now, I mentioned that I did the assessment in Hong Kong with 300 people. And when we do the subgroup analysis, actually, we can identify who are cognitively impaired and who are having some malnutrition. So it's easy for us to follow up. And by the time when we know about the issues, then we can take some actions to help them. But the downsides of the digital health, of course, I think is the data security issues. Like the WHO ICOPE app, at the moment, we are not very sure whether the data can be downloaded by us. Obviously, it has to be negotiate with WHO and see how's that going on and how to, I think there are a lot of issues about data security, whether the data download to the university server or to a particular designated server will be another issues. So the data security issues has to be resolved by the time when we work out the digital health in ICOPE. And of course, how long we can keep the data, and there must be some contractual issues over here. And who owns the data? Would that kind of data used by the researchers or used by the clinicians, or actually the data should be owned by the clients and their relatives? So it has to be sort of resolved before we actually finalize the digital health issues. So considering the possibility of doing some comparison across countries, I think data transfer is inevitable. Whether who can transfer the data to where, to whom, and that would be another issues. So I just raised this point for the sake of making people to think about that. So I think this would be a point for our discussion.
Thank you very much, Professor Leung. I think we can come back when we have a discussion. So may I introduce the next speaker, the panelist, Ms. Tammy Leung, Service Director at Aberdeen Gai Fong Welfare Association Social Service Center. And I believe she'll be talking about issues from a community perspective. Please, Ms. Tammy Leung.
Okay, thank you, Professor Wong. Good afternoon. This is AKA Tammy Leung. I'm glad to be invited to share our related elderly services experience. Digital health and integrated care of older people also echo unique needs and goals, making care plan more personalized and precise. Applying digital health in elderly integrated care is an irresistible trend. From our AKA Elderly Services experience, here we would like to share several prerequisites which may facilitate to develop digital health in integrated care of older people in Hong Kong. Firstly, popularization of digital health. In our daily elderly service operation, according to the past few years' cumulative observation, a certain number of elderlies seldom use online service since the lack of related IT devices. Please play the video.
78歲嘅鄺婆婆冇智能手機，一直唔識得掃安心出行。呢一日喺社工嘅協助下，嘗試學下。
Few seconds TV broadcast interview we just released, which is very common in our service target. Popularization of digital health is the first phase via providing wearable smart health care devices to elderlies, free Wi-Fi, smart city, etc. It facilitates the future development of digital health in integrated care of older people in Hong Kong. Secondly, majority of our elderly members and their caregivers are not familiar with IT technologies. Let's take an example. A few months ago, we invited them to join Jockey Club Digital Support Project for the elderly. Some eligible elders declined to participate in the project, at first, only to low digital literacy. After consistent encouragement, they finally applied and joined related training. One of critical success factors for future development is to empower related target actualizing their bottom-up participation, such as they're capable in carrying out regular digital health measurement in their local community. Please play the video.
78呢間社福機構又話會加強培訓義工同埋舉辦活動，教導長者點樣掌握使用智能手機同埋應用程式嘅方法同埋技巧。
Personalized training, assisting them to use digital health device with positive reinforcement from cross sectors such as NGOs, neighborhood network, and resident organizations enhance their motivation, treatment adherence through behavioral change. A paradigm shift of elders and their caregivers from passive to proactive role is expected to be achieved with hard and soft infrastructure to facilitate the digital self-management trend in the future, such as they are capable in carrying out regular digital health measurement in their local community. Here, I would like to highlight that empowering health and social care professionals and community is also significant. And tripartite partnership among government, social sector, and business sector for data collection, analysis, etc., is also very important. Early identification of elderly risk at community level through local stakeholders and district support network. Finally, collaboration between NGOs and primary care service providers to yield new service insights and service delivery modes via digital health. Thank you.
Thank you very much, Ms. Tammy Leung. So may I invite our last panelist, Dr. Joyce Tang, to share her wisdom on digital health in integrated care of older people. So Dr. Joyce Tang is the medical director of the United Christian Methodist Community Health Services, and she's also a family medicine specialist. Thank you, Dr. Joyce Tang.
Thank you, Professor Wong, for your kind introduction, and thank you also to the Jockey Club Institute of Aging for inviting me to join this panel. I'm representing the United Christian Neversalt Community Health Service, which is a primary care NGO in Hong Kong. We have medical and health services and social services. So we're sort of like a mixture already of medical social collaboration. I'm going to present what we have been doing up to this point in using digital technology in the integrated to try and achieve integrated elderly care. And then I'm also going to let you know what worked okay and what didn't really work that well. And then a wish list of what we could do or what's the future. Well, community elderly care is a major part of our work as we aim for aging in place. I'll just share our PowerPoint. Can everybody see this?
Yep.
Okay. Yep. Okay. So what we're currently doing. So we've been digitalizing our clinic medical records since 2007. And it's been a long process, but it's been definitely a real learning experience, and it's helped us to improve our quality of care and give us better continuity of care. When we started doing this, we tried to do it cheap, and we were looking for off-the-shelf package that we could just buy, and of course we couldn't find one. So we asked a company to help us design it, and with this system, not only can the medical clinic digitalize the medical records, but also allied health. Because we have dietitians, physiotherapists, clinical psychologists, they can all use this clinic record system, and it allowed better communication between the providers. It has a really important function for primary care, which is an inbuilt recall and reminder system, which enables us to provide better continuity of care. And another special feature of this is that we have developed our own elderly health assessment program, which can also design, like we design a personalized healthcare plan for each elderly person. So that's linked with their medical records. In the medical setting, we also started using SMS to send reminders to patients, and this worked quite well. We started doing a WhatsApp booking. Unfortunately, this did not work well, or maybe it worked too well, because within like a week of opening this up, we had over 1,000 WhatsApp, such that our staff couldn't really cope. So we've quietly reduced that scale. Our healthcare professionals, including doctors, nurses, physiotherapists, over the years have joined the EHRSS system, and also we encourage our elderly and service users to join the EHRSS. And in the process of digitalizing, not only the in-house, the clinic medical service, we have an outreach elderly health assessment service where we go on home visits to conduct elderly health assessments. And we're now trying to develop an app and digitalize this tool. Right, so that's in the works. We trialed an app for booking for one simple health check program, but we found that only appealed to the younger people. The elderly couldn't really use it very, very well. We have installed 2 eHealth stations in 2 community centers, and the pandemic, the COVID pandemic, also triggered us to fast forward and trial teleconsultation. Now, teleconsultation is not only between the medical clinic doctor and the elderly patient, but also allied health, dietitians could use it. And we also use tele-Zoom for health education purposes, such as our regular diabetes workshops and other healthcare programs for those who were able to use Zoom. However, a lot of elderly don't know how to use Zoom. And even if they have a smartphone, as Tammy said, they may not know how to use it. So as part of our Jockey Club Healthy at Home Elderly Support Program in the community, we have been conducting workshops for elderly on how to use smartphone for health for over a year. starting from the real basics, such as teaching elderly how to use the scan function, how to upload things, to actually which are the health apps that might be useful to them, such as HA Go, EHRSS, and also directing them to some more reliable health information websites such as the CHP. So this is an ongoing process, and we have these workshops regularly. And finally, in our medical clinic, we are still in the process of trying to link up with the EHRSS, which is proving to be much harder than we thought. It's more technical than we thought and a lot more costly than we thought. So this is still sort of stuck, not really going ahead very well. Okay. So for the future development of digital healthcare, this is like a wish list. We think that we need tools that can bridge a medical social divide for elderly who have like multiple problems, cognitive problems, health problems, some sort of tool that can be used by both medical and healthcare workers and also social care workers. Tools that can help us enable both types of workers to assist the elderly person. Tools that can serve multidisciplinary teams, because in primary care, you never really work alone. Tools that are user-friendly to older people, like through the smartphone workshops. The older people have given us feedback on what they would like to see happen, such as tools that have enabled them to see a bit better, for visual, a good visual contrast on the screen, bigger fonts, maybe even tools with a bigger button would be better for older people. Tools that can be used for health assessment, monitoring, communication, referral, follow-up, and also perhaps give some personalized health education messages, some feedback to the elderly person. If possible, these outreach health tools to be able to sync with their health records. But for this, we have to consider the security, which several speakers have mentioned before. And all this has a cost. So we hope that any future development of digital health could be, the price could be friendly to the users. And finally, healthcare workers also need some support in the IT field, because we are not really the specialists in IT, and sometimes we also need some support in knowing the latest developments and the possibilities that digital technology can bring to healthcare. So that's my presentation and sharing. Thank you.
Thank you, Dr. Tang. We have 3 minutes left. So it seems that maybe I can summarize a little bit. It seems that the recent COVID wave have pushed for more use of telecare, and in different settings we've experienced various challenges in various. We're at a phase or at a stage where we should have more investigation, intervention to overcome these barriers, such that older people in primary care setting can better use it. And this need, I believe, is not only for the older adults, but also for the caregivers, healthcare providers, and also organization. So, so we have 2 minutes left. So I don't think I can open the floor for Q&A. Maybe each one can say one thing that you would like to immediately implement to help with the telecare. Maybe starting with Dr. Elsie Hui, what would you say?
Yeah, one word: medical social collaboration.
Yes, that's the key theme of today's conference. Wonderful. And Professor Angela Leung, what would be your wish list?
I think it's all about stakeholders' views.
Yes.
Many of this development has neglected the stakeholders, including the older people, caregivers, professionals. I hope that in future, more involvement of the stakeholders' views could be included.
I think we should involve more of the older people at the center of our planning, instead of just doctors. And the next one should be Ms. Tammy Leung.
to empower the elders and caregivers and practitioners to the use of the digital health system.
Great. So, and especially when you have a lot of community experience in that and building up resources.
Thank you.
And Dr. Joyce Tang, you have a very long list earlier on, so I wonder if you can find one that is particular that you really, really want to push for.
Okay, without overlapping previous speakers, I think I would like to see actually more forums like this one, where different people who are working with elderly community care can share their experience in digital technology. Like today, I've learned a lot. Oh, I didn't know. Oh, there's people are using these apps already, and so that there might be like less duplication in the future. I mean, of course, like different organizations might have their specific programs and specific needs, but perhaps there might be some platform or some room for sharing so that we can pull together some resources and together benefit more of the community elderly, more sharing.
Great. So Dr. Joyce actually make a very good concluding remarks for me. For more sharing of best example and sharing platforms, and also involving various stakeholders and also maybe some of the people who are using the services as well. So now it's 4 p.m. So I will call these sessions an end to these sessions. And thank you very much for enlightening us on various aspects of the integrated care that is provided, and also on the latest development of the ICOPE applications. So thank you very much. So I will give the mic back to the MCs. Thank you.
Thank you, Professor Wong, Dr. Hui, Professor Leung, Ms. Leung, and Dr. Tang for the informative and insightful sharing. Now we will have a short break, and please come back soon for the next presentation. While you're waiting for the next sections, you may browse our online platform. The link of the platform is in the chat box now. You can find out the context of today's symposium, such as today's rundown and speakers' biography, as well as the background, findings, and achievements of the CUHK Community eHealth Care project. Ladies and gentlemen, welcome back to the symposium. Next, we would like to invite Professor Martin Prince, Professor of Epidemiological Psychiatry, Director, King's Global Health Institute, Assistant Principal Global Health, the United Kingdom, to present Intrinsic Capacity and its Associations with Incident Dependence and Mortality. Professor Prince, please.
So thank you very much for that kind introduction. And apologies to everyone that I find myself here on the street outside my hotel in Addis Ababa, Ethiopia, which is a nice place to speak to you from, but there may be some background noise. It is, strangely enough, a stronger Wi-Fi signal here than it was in my hotel room. So let's see how this goes. But I'm here today to talk to you about the WHO's program on integrated care for older people. What I'm going to try and do is give you some background of how the concept of intrinsic capacity grew up in the context of WHO's framework for healthy aging. And then I'm going to be focusing on some of the kind of the story of the development of the ICOPE guideline, the rationale for that, how we went about it, and then look at some of the many potential implementation issues and challenges around actually bringing the ICOPE guideline into practice in a range of high-income, middle-income and low-income countries. So first, to acknowledge the contributions of all my colleagues in the 1066 Dementia Research Group, the funders of the 1066 Dementia Research Programme, and my friends and colleagues at King's College London who've worked with me over the years, 20 years now, on this body of work, initially focused on dementia, amongst older people, but increasingly focused on the full range of multimorbid conditions that afflict older people. Next slide, please. Thank you. So I think we'd all agree here with, sorry, previous slide. Previous slide, thank you. So I think we'd all agree here with the ex-Director General of WHO, Dr. Nakajima, who in 1997 said, increased longevity without quality of life is an empty prize. So the key issue here is that we're all living longer nowadays, but that isn't really the issue. It's whether we can actually add life to years as well as years to life. Next slide, please. We did a series for The Lancet back in 2015, which was the Lancet's first series on aging and health. And one of the key kind of issues that we had to deal with here was after 3 Lancet series on non-communicable diseases, what was there actually new to say in a Lancet series on aging? And I think the key issues that we came up with were firstly that aging is characterized particularly by degenerative disorders and those that afflict the mind and the brain. Including dementia in particular, but also stroke. If you look at the prevalence of multimorbidity, living with 2 or more long-term conditions, this, like the prevalence of dementia, increases exponentially with age. Multimorbidity as an issue within our societies is very strongly concentrated in older people above the age of 60. And all of these health problems lead to the experience of living with disability and ultimately to needs for long-term care. And in many contexts, older people live under the most fragile economic circumstances and with very little social protection provided by the state. Older people matter because of the substantial disease burden, the social care burden, and the costs arising from that, which again are very much concentrated amongst older adults. And the challenge is really providing access to effective age-appropriate healthcare, but also effective integrated social care so that the needs for care of older people are seamlessly met. And in many states worldwide, the government actually does very little in this area, often intentionally relying on systems of family care. So they don't do anything with regard to the 3 S's, supporting existing caregivers, supplementing the efforts that they're able to provide when their capacity is exhausted, and ultimately substituting the informal care that family carers can provide with state-provided systems of care. Next slide. So my starting point on this journey was the WHO's Mental Health Gap Action Plan guidance, which was designed to scale up access to mental health care in low and middle income countries, essentially through the tactic of task sharing. So far too few psychiatrists and specialists. So instead of that, we need to actually recruit and engage the primary healthcare and community healthcare workforce in providing simple interventions for a range of mental health conditions. It was great that WHO included dementia, and I was particularly involved in developing the guidance for that, and it was good. We put together a simple structured package of care that acknowledged the continuing and evolving and developing needs for care of people with dementia, and interventions that were simple enough that you could train community health workers and primary healthcare staff to actually carry out this work. The problem with this was that WHO member countries were offered the choice of which of these packages of care they decided to prioritise. And to my knowledge, to date, no country has actually prioritised the introduction of the dementia care guidelines. They just don't see that as being a priority amongst the other range of mental health conditions. Next slide, please. And perhaps part of the problem with this is what I referred to earlier as the issue of multimorbidity in older adults. So it's all very well to have a guideline for dementia, but people may well say, well, what about a guideline for stroke or a guideline for cardiovascular diseases or cancer? Because these are all very prominent in older people amongst a range of other health conditions, for example, affecting vision and hearing. And when we looked at this in 1066, we found, yeah, for sure, in low and middle income countries as well, the prevalence of multimorbidity rises exponentially with age, and it's strongly associated with the prevalence and incidence of needs for care in older people, and also accounts for a large part of the hospitalization of older adults as well. So next slide, please. Multimorbidity certainly matters in low resource settings as well. And this has a lot of implications for the care provided for older adults. So the first thing is that care needs to be holistic. It shouldn't be caring for individual organs or caring for individual conditions, but you need to treat the person. And that care needs to be person-centered in orientation. So it needs to take into account what is important for the older person. What do they have reason to value? And what would be their preferences and their priorities about how care for them should be structured? And we need to streamline the care provided for multimorbid conditions in older people so that there's an emphasis on the continuity of care, because these are all chronic long-term conditions, and the integration of care across individual conditions as well. This is really important. If you apply all the individual guidelines for all the individual conditions that older people have, you end up with a tremendous burden of care for the older person, often with huge out-of-pocket costs. So that care needs to be planned and it needs to be coordinated. Next slide, please. So how does the WHO construct of healthy aging actually begin to address these issues? So a PhD student of mine, Joyce Tang, who now works at WHO on ICOPE and its implementation, and I started thinking about this in the early 2010s, and his PhD was focused upon developing a basic set of assessments for community health workers at the primary care level they could administer at home that could identify, in essence, intrinsic capacity problems. So when we went to WHO and spoke with John Beard, he was really enthusiastic about the idea of developing an integrated care guideline. Because he was working on a framework for healthy aging, and intrinsic capacity was at the core of this. So that's the sort of brown box in the middle of the blue box. And when we break down the brown box, you see that intrinsic capacity is everything under the skin, essentially, in an older person, their genetic endowment, the health conditions that they have, the physiological changes in their body with age that lead increasingly over time to the development of further conditions, to pre-frailty, frailty, and ultimately to needs for care. So next slide, please. So that by focusing early on declines in intrinsic capacity, in areas like locomotion, getting around, cognition, thinking and understanding, psychological factors, mood, nutrition, both overnutrition and undernutrition, urinary incontinence, and so on. As and when these declines first become apparent, you can then hopefully change the trajectory of aging such that people either don't become or there's a delay until they become pre-frail or frail, until they develop actual disabilities, and until the level of care required for those disabilities and functional limitations mean that they develop dependence. Next slide, please. I think what's great about the WHO model of healthy aging and intrinsic capacity at the core of all of this is that we now develop a kind of life course approach to promoting healthy aging in an older person. And early on, when it's individual problems with individual intrinsic capacities, a lot of this is about health promotion and disease prevention, shifting as one progresses to more severe problems with intrinsic capacity, to medical care, evidence-based interventions and treatments. And then as disability and needs for care arise, then the focus shifts again more towards rehabilitation and ultimately to palliation and end-of-life care. So this complete spectrum of care, from health promotion, disease prevention, medical care and treatments, through to social and medical rehabilitation and palliation, really is absolutely at the core of the principles for universal healthcare. So health systems should be providing all of these for all people, but including older people. And this is really what ICOPE is there to do. Next slide, please. So we developed at WHO the Integrated Care for Older People guidelines. And you can see that this is a horizontal approach and a syndromal approach. It doesn't actually deal with individual conditions. It's not about diagnosing dementia, stroke, or Parkinson's disease, but the horizontal impairments or declines in intrinsic capacity that underline all of them. Next slide, please. So the guideline was produced by a guideline development group according to structured WHO rules and practice. So this was, to the extent possible, absolutely evidence-based with systematic new reviews of the literature to support which interventions worked for each of these intrinsic capacity areas. Next slide, please. The guideline was actually released in 2018. And I'm not going to read out here all of the evidence-based interventions that we identified, but just to highlight that the bulk of the evidence came from well-resourced high-income countries. So there's a margin of doubt, a level of doubt as to the extent to which interventions typically administered in high-income countries by physiotherapists, dietitians, and nutritionists can actually effectively be applied by non-specialists in lower middle-income countries. This remains to be tested, but in the view of the Guideline Development Group and the WHO regional offices who reviewed these recommendations, they felt that in principle, these interventions should be feasible and could be task shifted down to a lower level in the workforce. Next slide, please. So one of the great things about the ICOPE approach and its integrated approach is that you can see here all of the interventions in the boxes on the left. And you can see their interactivity. So, of course, an intervention for visual impairment by providing reading glasses or cataract surgery should improve visual acuity, but it may well actually improve confusion and behavior in an older person with dementia, and it may well improve mood in someone in whom the loss of visual function has led to a significant impairment in quality of life. But I guess the ultimate outcomes that we're trying to achieve here is an improvement in functional ability or a slowing in decline, and an improvement in health-related or actual quality of life. Next slide, please. So now we get to the issues and difficulties in implementation. The first thing is that if we use one or more declines in intrinsic capacity in any one of those areas that we've mentioned, across our 10 dementia research group countries in Latin America, India, and China, about 75% of the whole older population, community population, would have had one or more decline in intrinsic capacity. So potentially taking on screening and intervention at community level on 3/4 of the older population could be an enormous task. And you'll see that very few of those, that's the black part of the bar on the right, actually have established needs for care. And that's what we're trying to prevent. Next slide, please. And the bad news, if you like, but important finding with regard to what is the target population, is that actually even those with just one or more decline in intrinsic capacity without pre-frailty or frailty actually have a significantly increased risk over 3 years of developing needs for care. So a 1.72 times increased probability of developing needs for care. So arguably the target population is absolutely correctly stipulated at one or more decline in intrinsic capacity. There's 60 to 75% of the older population in low and middle income countries. Next slide, please. And the same is true for mortality. So if we look at the survival curves, you can see that compared with people in full health, mortality is substantially increased or survival substantially reduced, even in those that have isolated declines in intrinsic capacity, the very early stage of this trajectory of aging. Next slide, please. Within all of this, within the mixture of the different types of declines in intrinsic capacity, it's clear that the brain is a really important organ, and the functions of the mind are really important as well. Low mood and cognitive impairment are the commonest declines in intrinsic capacity amongst the over 65s. Most low mood is actually subthreshold depression, as opposed to actually depression of clinical significance. There are high levels of comorbidity between cognitive impairment and depression, particularly with increasing numbers of declines in intrinsic capacity. And also, these problems of the mind and brain are by far away the strongest drivers of disability and needs for care in older people. Next slide, please. So we need to make sure that we have really strong interventions for subthreshold depression that would take into account the fact that subthreshold depression is often comorbid with cognitive impairment. What we didn't have available to us in the guideline development group was the first really good trial, large scale, in a low and middle income country, India, of a psychological intervention, a brief psychological intervention, behavioral activation, which is basically just finding out what pleasurable activities older people have foregone, and then trying to find ways to re-engage with them, recruiting the assistance of their caregivers and family members as well. This intervention, delivered by lay health workers, reduced by 2/3 the incidence of clinically significant depression amongst older people with subthreshold depression. Next slide, please. And in thinking through how an intervention like this might actually work, as far as the comorbidity with cognitive impairment is concerned, we have a problem with this. So antidepressants don't work for subthreshold depression, neither do they work for depression in dementia. Most psychological therapies do work for subsyndromal depression. We've seen that's the case in low and middle income countries for behavioral activation as well, but they don't work for depression in dementia. Cognitive stimulation therapy, there's some borderline evidence that this may improve cognition in dementia, but it's not associated with any improvements in mood for older people. But behavioral activation does actually work for depression, for subsyndromal depression, and for depression in dementia. And it probably includes, next slide please, it probably includes some of the effective components on cognition of cognitive stimulation therapy, which is basically social engagement and social communication. Next slide, please. So we're coming down to the last couple of slides in the talk, which is the challenges for implementation. And these are really important because we mustn't think that we can take the generic version of ICOPE off the shelf from WHO, implement it all around the world and expect it to work. So the answers to all of the following questions are completely context specific. They're specific to the health system in which you're implementing ICOPE, the resources that you have available, the structure of your health service and social care. They're probably also culturally specific as well. A nutrition intervention for undernourished older adults in Hong Kong would look completely different from a nutrition intervention for older adults in South Africa, for example. So the questions are, what should we be implementing? And although the guidance says, in principle, what you should be implementing, i.e. dietary advice, first of all, for undernutrition, followed by nutritional supplementation if dietary advice doesn't work or nutritional impairment is severe. But in operational terms, exactly what should that intervention comprise? Same for mobility, same for falls prevention, same as we've seen for low cognition and low mood. And again, each health system needs to look at what is available locally, what is evidence-based, adapt things from other countries and other settings. There's the who question as well. So who should receive the intervention? So where should we target the screening in the first place, as I've said, but who actually administers the interventions? This is designed as a task-shifted intervention. It's designed ideally to be administered at home in the community or in a community facility, but other countries may find it more appropriate where access to healthcare facilities is better to actually administer this intervention in a healthcare facility. So there's the where question as well. The when, so obviously this isn't a one-off because these are chronic, evolving, long-term conditions, but you initiate a system of care, you pick up all of the unmet needs, you address as many of those as you can, but then what should be the intervals of reassessment and reevaluation later on? And then there's the how you should implement it, taking into account all of the potential health system barriers and facilitators to actually implementing the program. Next slide, which I think is more or less the final slide. Next slide. Yeah, so these are the specific areas. Sorry, one slide back. Sorry. So these are some of the specific areas I think that need consideration. So to make this a truly holistic intervention that seems to the person and the family receiving it to be one intervention, not many, one for mobility, one for cognition, one for depression, you really need care planning that makes this a holistic intervention that completely integrates all of the elements for a person with many declines in intrinsic capacity and is completely patient-centered. So it takes into account the preferences, the values, the priorities for the person being cared for and their family members. We need to somehow find a way to streamline the delivery of the different elements. So what if an older person is undernourished, has problems getting around, and is confused? That could potentially be 3 separate interventions. But you can actually look at the different components of the intervention according to the target. So some of the intervention components target the older person directly. Others of them target the caregiver. Others of them target the environment, the home environment in which the older person lives. And then what is the objective? Broadly speaking, the objectives are changing the environment, improving knowledge and skills, whether it's of the caregiver or of the older person, or it's a direct medical intervention on the older person. So grouping the different interventions that are provided into those categories, it may be that, for example, all of the interventions designed to improve caregiver knowledge, you can give together in one package, whether that's relating to nutrition, to mobility and falls prevention, or to supporting a cognitively impaired older adult. Next, referral. So not all of these interventions can actually be administered and dealt with in the home environment. So many of them, for example, cataract surgery or pretty much any visual intervention will require an ophthalmologist or optician assessment before the problem can really be diagnosed and an intervention can be planned. So the referral pathways need to be sorted out. Sorry, if we can go one slide back. So the kind of final key things that I wanted to mention is the significant importance, I think, of digitalization of the ICOPE delivery platform. So one of the things that we can do is we can use digitalization of the assessment at the beginning to develop algorithms that would suggest ways of streamlining the delivery of the intervention in the way that I had kind of previously highlighted. Secondly, we can use this to develop a digitalized electronic patient record. And if these assessments and some of the interventions are being administered in the community, it's very important that the record of that clinical activity is actually available to the facilities at primary care level and secondary care level where the older person is receiving care. But probably most importantly, we can then aggregate the information about the interventions that are being provided and their outcomes at the level of the healthcare workers that are delivering the interventions at the level of districts or regions. And we can use that information, which is a health management information system, to inform quality improvement activities, because we can't assume that when we implement ICOPE right at the beginning that everything is going to work smoothly. And if we've got process data and outcome data, we can see where it's working, what the residual barriers and obstacles are, and introduce quality improvement activities, training, supervision, support, changes to the way that the intervention is delivered in order to improve the outcomes. And finally, research is needed everywhere. And I would urge people not to rush into cluster randomized controlled trials of the whole package, because really each element of the package needs to be looked at and its implementation optimized before everything is stitched together. And then the whole thing is actually administered as a unitary whole. So those non-randomized pilot trials are, I think, hugely important within the whole scheme of things, wouldn't take long and really need to be prioritized as the first activity. And then I'll just leave you with the final slide because it summarizes some of the potential benefits of implementation. My apologies for going a little over time. My computer is telling me my internet connection is unstable, but hopefully you have been able to hear me and can hear me still. So sorry, that was the finish. I was just leaving that slide for people to read through as a summary of ICOPE as a public health approach, its advantages and what it hopes to achieve. Thank you.
Thank you very much, Professor Prince. Here comes to the 5 minutes Q&A sections. Ladies and gentlemen, you're welcome to raise your questions. Please type your questions in the chat box, and Professor Prince will try to answer it accordingly.
Do my best. I don't know that I can see the chat box is the only issue. But,
okay. So,
yes,
Professor Prince, this is the first question. You mentioned DIC screening is suitable for persons before being pre-failed. Has anyone health system integrated ICOPE with LTC in the community? Wonder how they accomplish that, especially in LMIC.
Yeah, so that's a very good question. I think, to be honest, we're in the very, very early stages of this. So I've just been re-engaging with WHO recently, seeing some of the work that's been done, predominantly in high-income country settings, and in part of those settings where, because of a highly developed, pre-existing specialist geriatric care services, they've been in a good position to actually take this out to a community to extend the scope the care that they provide. In low and middle income countries, WHO has plans to implement and to do so within an experimental framework, which I think is very important. And what I'm hoping to do through the work with them is, as I said, to ensure that the initial focus is really on implementation science, so that we can understand what we're trying to implement, how best to implement it, and to really try and optimize this intervention for the different settings before we move straight away to trying to evaluate a whole package that hasn't been properly thought through and properly planned, because that's likely to fail and there may be limited learning from that. So I think this is going to take a few years to get it right, but hopefully with WHO impetus behind this, and with people like myself that are trying to get research funding to actually do work focused in low-income countries, in my case in sub-Saharan Africa, then I think we're going to build up an evidence base over time. But it really is a case of everyone doing their bit, I think, in this area to support the initiative itself, which is a very, very good one, but to provide the evidence that would enable this to go well.
Okay, once again, thank you, Professor Prince, for your presentation and also to answer our questions. I do hope you have a very nice day in Africa. Thank you very much for joining us. Thank you. So the symposium now comes to the end. May we invite Professor Jin Wu to give concluding remarks for this symposium. Professor Wu, please.
So what I'm going to do is try and summarize the whole day, the kind of take-home messages. I think you all agree with me that we have learned a lot. In this field, we need to keep up with what everybody is doing in other places to inform our own practice. And I think I try to include all the stakeholders in Hong Kong, but if I've left anybody out, sorry about that. So you can hear that throughout the day, there's some recurrent themes. So primary care, accessible, coordinated, comprehensive continuity of care, and the use of technology plays a vital role. And then some other themes are that we have various service providers and they're all doing different things towards care of older people. And digital technology is an important part. We have a vibrant medical social collaboration going on. Another recurrent theme is empowerment, person-centered care, what matters to the care recipients, i.e. the older people and the carers. The need for older people to take ownership of their health, not just be passive recipients. There need to be strong motivation for them to change their behavior towards health maintenance. And yet we have to tackle the problem of the digital divide. It could be that eventually if somebody gets very old, then we have to target the carers rather than just educating older people. Another theme, there are multiple providers, multiple funding sources, and some of them are overlapping. So the message here is that there are a lot of people, a lot of resources. Somehow, if we could harness them all into a comprehensive, streamline the whole service, we could be able to achieve much more. So streamlining from neighborhood council care centers to DHC. If they don't have health professional support, then they can refer more to EHC, DHC. But some of the big NGOs may be able to do more because they have multidisciplinary team, including doctors. So there's a lot of options. But primarily, we want to highlight the need for chronic disease together with aging process. But both are important, as Professor Prince highlighted. It's a combination that we need to target. And in this regard, what I mentioned earlier on, this life course approach, I think there's a lot of room for us to develop the more upstream services. So before you become pre-frail or frail, to maintain your cognitive and physical function. So in that regard, some automated brief screening followed by more detailed assessment if necessary, followed by personalized care plans will be important. And here, digital technology will have a very important role. And the question of where we do this, currently in Hong Kong, if you look at the landscape of service provision, it's really the huge network of NGOs that covers the whole of Hong Kong, and therefore very convenient, accessible to the local neighborhood. And so I think that it would be logical to continue to develop these ideas based on this territory-wide network of NGOs, and then to develop suitable links to various existing services, such as elderly health centers, DHC, and hospital authority outreach teams. The link should be more accessible, as Dr. Kong mentioned, that she needs to refer people from HA downwards or upwards as well. So I think more communication within the whole landscape of service provision would be really useful. So this applies to assessment and services. And this is where digital health will have a very important role. And I think the best way to develop it is probably app-based, because the person and the carer can have access to it. So finally, I'd like to thank all the participants for speaking and participating and commenting on this topic. We all learned a lot from these talks. And because otherwise we don't really know what's going on. So I hope that we have had a very comprehensive view of what's happening in Hong Kong right now and how we may develop in future, picking on the good developments that's happening elsewhere. And of course, last but not least, we would like to thank the Hong Kong Jockey Club Charities Trust for having the foresight to initiate such a project in 2016. Thank you.